introduction to clinical trials, and then really start to think through where does any clinical research come from? How do we start from an idea or a problem and turn it into clinical research? So first of all, let's just go through clinical trials. And here's just a simple diagram explaining to you the different phases of clinical trials. You might have heard people talk about phase 3 clinical trials or phase 2 clinical trials and maybe don't have an understanding of it. So this just summarizes really the kind of progression through clinical trial phases. So before we start testing things in humans, and here we're largely talking about kind of drugs, vaccines, kind of therapeutics, preventive things, but you can use the same kind of framework for thinking about other things, diagnostics and things, but generally we're talking about drugs, vaccines. So obviously there's often work that you do before you even start testing something in a human. So that would be studies in the lab and studies in animals. But once we get to humans, then we're talking about clinical trials. Must be some better way to do this. Then essentially what you're doing here is you're getting bigger and bigger, and your aims are changing as you go through these phases. So although here it has phase 1, phase 0, you can kind of forget about phase 0, okay? But phase 1 is a study where you're going to do it in a very small number of people, and you're doing that to try and see whether this new thing you've developed, whether it's a new drug or a new vaccine, whether that is safe. And you're trying to start to understand what's the correct dose that you should use this drug at in humans, okay? And sometimes that will be in people who don't actually have the condition that you're thinking of treating. It may just be healthy individuals, but you want to give them this new drug and see whether it's safe. A phase 2 study is then getting a bit bigger, and you're getting more of an idea about safety, and you're starting to get an idea about whether this thing is going to work. Is it going to have any effect that you're hoping that it has? So in treating a condition, whether it's showing any sign that it improves survival from that condition or improves cure of that condition, or whatever you're trying to achieve, okay? And then phase 3 study next time we need to organize to have someone from IT here, otherwise it's just a bit I don't know why it's doing this. Then a phase 3 study is what you probably think about when you think of clinical trials. It's when you're really testing it now in a large number of patients to see whether this thing works, and again, whether it's safe in that group. And so you're doing it in a big enough number of people that you're going to be able to say whether this thing works or not, whether it does what you want it to do. And then phase 4, again, less important. This is usually when a drug is already authorized, it's already registered. So in South Africa, that would mean a drug that's already approved by SAHPRA for an indication, but you want to do more research to understand how it works as you start using it in a bigger population of people, and whether it's safe as you start to use it in routine practice. So that's a phase 4 study, but that's after you've shown that something works, the regulators approved it, clinicians have started to use it, and you want to understand better what's happening. So just to give you some examples from here of these different phases, just taking you through these steps. Here is an example of a recent phase 1 clinical trial conducted here in Durban by Caprisa. So just the group above us here. And here, this is a phase 1 study that's looking at essentially vaccines or candidate vaccines for HIV prevention. But what they're really testing is what are called broadly neutralizing antibodies. And so for this study, they're doing it in HIV negative women, and they're doing it in a certain age group. And this phase 1 trial includes 42 participants. So you can see a very small number of participants. There's no placebo control. So all 42 of these people that participate in the research are going to get what's being tested here. Yeah, because what we want to see from this is just whether this seems to be safe when we give it to human participants. And so what their primary outcome is, what they're looking at chiefly, is adverse events, and particularly kind of how people react to the injection of this broadly neutralizing antibody. So does that make sense? Can you see here that, okay, 42 is a small number, but let's say all of those 42 people got a very, very severe reaction to this injection of the broadly neutralizing antibody. Do you think you would then carry on testing that product? No, because that would be a signal that there's something seriously wrong with this, and it wouldn't be safe to continue using it. If nobody develops any serious problem, does that tell you that it's safe? Yes? Does it?
Well, not in the entire population of the world, but in this population, and those populations should be representative of the population they're going to treat now.
Okay, but do you think doing it in 42 people is enough to tell you that something's safe? Not really, is it? I mean, when we think about side effects, serious side effects of drugs or vaccines, how common is a kind of serious side effect be? So let's say, so who can think of a serious side effect of the COVID vaccines? Any of the COVID vaccines? Like life-threatening or, okay, anaphylaxis, yeah. So how common is anaphylaxis with drugs or vaccines? Rough, relatively common. True anaphylaxis. Yeah, certainly. Yeah, and probably less than 1%, and maybe 0.1%, something like that, true anaphylaxis. So maybe 1 in 1,000 or so. So when you look at serious side effects of drugs, vaccines, you're often looking at less than 1 in 1,000 kind of frequency. So clearly doing a study in 42 participants, yes, something might happen to one of those 42, but if nothing happens to them, you can't say that that's completely safe. So the point here is just that, of course, you need to keep going with these phases of the of the clinical trials. Well, usually it will be calculated by a statistician, but often at this stage, it's a little bit thumbs up what you're actually looking for. So you will have some estimate of that here you're able to pick up some serious adverse event if it happens at a frequency of X% or so. Okay. But really, these early trials are not so much the kind of sample size calculation is not so complicated. Okay, what you're really doing is just saying, okay, I'm going to test it in a reasonable number of people to get a sense of the safety and whether we progress to the next step. Okay. Do you think this trial is going to tell you anything about whether these antibodies work, whether they prevent HIV? Why not? Well, they will be exposed. They live in KwaZulu-Natal, no? Yes, so they're HIV negative. They have to be HIV negative to join the study. Okay, but is it going to give you a robust sense of whether it works? No, not really, because you've got a very small number. And even though I kind of jokingly said, well, clearly these people are at risk of getting HIV because they're young women living here where the incidence of HIV is very high. But of course, it's very likely that maybe over the course of a year or so, none of these women will become HIV positive. Yeah. So you can't at this stage get any sense of whether these drugs work. And then the other thing is we've got no control. We've got no placebo. Yeah. So we would have no way of saying whether these antibodies were actually preventing HIV. So does that give you a sense of what a phase 1 trial is doing? So if we move on to a phase 2 trial, and here, this is the same product and the same intervention. So Caprisa then progressed, and this is a study that's still happening. The results haven't been fully released yet. But this is now a phase 2 study of this same antibodies. So you can see again, we're including HIV negative women. We've reduced the age range a bit. We've got just the younger women. Why do you think that might be? Because in the first study, we said it was women aged 18 to 45. Now in this phase 2 study, we've just got 18 to 30-year-olds. Yeah, good idea. I don't think that was the case. I think purely here what it is that now we want to start to get a sense of efficacy, whether these antibodies work. So we want to include people at the highest risk of the outcome. Yeah. And younger women are going to be at higher risk of HIV acquisition than the slightly older women. Yeah. So for this phase 2 study, we've just concentrated on the younger women. Okay. So now we're dealing with almost 1,000 participants. So you can see quite a jump, yeah, from 42 in the phase 1 study to now almost 1,000. And here we've got, again, our main outcome is about safety. It's whether anyone has very severe reaction to the injection or any other serious kind of adverse event related to these antibodies. So do you think here that this is going to tell us for sure whether these antibodies are safe? Better than the last one? Yeah? Would we be certain still? Might not be certain, but we're going to get a much better sense than the other one because we've got a bigger study population. Do you think we can start to get a sense of whether these work, of efficacy? Yes? You're nodding? Yeah? Why do you think we can start to get a sense of efficacy? Reduced the age, we've increased the sample size, and what else have we got in this study? A placebo. Okay, so how does that help us? We can compare. Okay, yeah, so all these things will help. And so in this study, as well as these primary outcomes about safety, there's also what we call secondary outcomes relating to efficacy and whether these antibodies do prevent HIV infection. But do you think that, again, is this likely to be enough to tell us for sure whether these antibodies prevent HIV? No. Roughly how many women do you think might become HIV positive, let's say over the course of just 1 year in this study? So let's say take away the intervention and just let's say we're following 1,000 women aged 18 to 30. How many of those do you think would become HIV positive by the end of the first year? Roughly. Say again. 300. That's a lot. Okay. So how did you get to that 300? There's a high prevalence, you're quite right. But is prevalence the right thing here to tell us how many of these HIV negative women will become HIV positive in a year? What is the, other than prevalence, what epidemiological indicator do we need to know? Incidence. Okay, what's incidence? People that acquire a disease over a certain period of time. So what's the HIV incidence roughly in young women in KwaZulu-Natal? Is it 30%? No. What is it roughly? Oh, why do we not know what HIV incidence is? One of the most pressing public health problems in KwaZulu-Natal. So probably something like, and here the problem is when you look at a trial population may not be the same as the general population, yeah, because people who come and join clinical trials may be different from people who don't join clinical trials. But let's just, for the sake of argument, say around 5%. Okay, and the reality is that's a bit high. But when you look at some of the trials that have happened in KZN, HIV prevention trials, that's the kind of incidence that we've seen, even in the trials. Okay? It's hopefully lower than that now, maybe 1%, 2%, but for the sake of argument, we'll say 5%. So how many of these women would become HIV positive? 50. Yeah. So that gives you a sense. To show that your drugs work, you would have to show quite a difference between those that got the antibodies and those that got a placebo. Yeah. So you're not going to have the size here to really be able to show whether they work. So just at a rough guess, how many participants do you think you might need to show efficacy of these antibodies? 1,000? Yeah, probably more than that. So probably looking at tens of thousands is the reality. So you get a sense that as you move through clinical trial phases, your study populations get quite a bit bigger. And it depends on the outcome that you're looking at and how common or how rare the outcome is, how big your trial's going to be. Just to now move to phase 3 trial, here again, I took a different example, but again, trials that happened here in KZN in South Africa recently, and this was one of the trials of COVID vaccines. So this was a phase 3 placebo-controlled trial of what the technical name for the Janssen vaccine or the Johnson & Johnson vaccine. Okay, hands up if you've had the Janssen vaccine. Okay, some of us. Okay. So here again, there were sites in Durban that were involved in this trial. And this trial now is including about 20,000 participants. And they were randomized to receive either the vaccine or a matching placebo. And here we were really interested in, does this vaccine work? So our main outcome was severe, moderate to severe COVID. Yeah, because that's what we wanted to see. Do these vaccines prevent you getting sick with COVID? There were also, of course, safety outcomes and other outcomes, but our main outcome here was efficacy. So do you think that this trial was big enough to demonstrate whether the vaccines worked? Yeah? How many of these participants would have got moderate to severe COVID? Small amount? Roughly how many do you think? 1,000? Bit less. So if you probably can't see very well, but here 116 in the vaccine group versus 348 in the placebo group. So about 500 overall developed the outcome, developed moderate to severe COVID. And even without fancy statistics, you can then get a sense, yeah, the vaccines worked. Yeah, 116 in the vaccine group versus 348 in the placebo group. So that sounds a lot lower, yeah? They didn't prevent it completely. They weren't 100% efficacious, but they worked. So gives you a sense of what a phase 3 trial is about, yeah? Sorry, 2 seconds. Okay, so any questions about clinical trial phases? Does it kind of make sense? Okay, so let's just shift to really taking a step back and thinking now more about kind of how do we come up with research ideas, or where do research ideas come from? And when we think about clinical research, ideas really come from doing clinical work. They come from being curious about what we're doing with patients and observing things. And that means just our routine clinical work. We should be asking questions. We should be wondering why people don't get better when we give them a treatment for a certain condition. We should wonder why someone dies after we've given them what we thought was an effective treatment for a certain condition. We should wonder why a diagnostic test has not given us a positive result, and we later find out the person has the health condition we were looking for, but that test was negative. We should always be curious about the things that we see with our patients. Does it make sense? And that's, of course, not specific to clinical research. That should be just good clinical practice, and becoming a good doctor is about being curious, about wanting to do the best for each individual patient that you're going to treat, and understanding what you're doing and whether you're doing the right thing for each patient. So let me just give you an example that's kind of relevant to some of the research that I'm doing currently, but hopefully you can kind of see as something that, again, is relevant to here. So let's just say I'm working at the hospital here and I'm getting frustrated because lots of my patients with TB meningitis are dying. Okay, and I keep noticing that despite what we think we're doing right, giving the right treatment, doing the right things, people are still dying. So I'm curious, why is this happening? You know, why are so many of my patients dying, and what can I do about it? So does that seem reasonable curiosity? Yeah. Can you understand this kind of observation? So this could come just from one patient, or as this is from a group of patients, that you're starting to notice a trend from what you're doing with your day-to-day clinical practice. So just to get you thinking off the top of your head, why might this be? So why are half of my patients with TB meningitis dying? What understanding would we start with here? Yeah, in the hospital. So these are my patients. They're in a good hospital. We're treating them, yet half of them are dying. Okay, nosocomial infections. Okay. Okay, yeah, you're going off a little bit on a tangent, but let's just think about the condition that we're dealing with first of all. So you're not wrong. It's a good suggestion, nosocomial infections, but let's just park that. Just thinking about the TB meningitis. Why are half my patients dying? Just some medication is not working. So the treatment that I think is the right treatment is actually not the right treatment. Okay? Okay, that's a good idea. What else? There's no right or wrong answers, just thinking, just to give a sense of how we start to think when we've come up with a problem. We start to think about, what do I know about this problem? Okay. Okay, so you're going ahead and saying, well, how am I gonna find out? By looking for common features, which is great. But yes, okay, maybe it's malnutrition, which is leading to other problems, right? What else? Maybe we're not giving the right dose. So maybe the drugs are right, but the dosage of the drugs is wrong. Great. What else? Okay, so is it a problem of age? Is it actually because all my patients are elderly presenting with TB meningitis and the outcome is different in that age group? Or the opposite, maybe I'm a pediatrician and these are all children where the outcome is different. Anything else? Yeah. Okay. Yeah, so is it actually the predisposing condition, HIV, that's actually the problem? And so they're not dying of TB meningitis, but actually maybe there are other complications of their HIV that are contributing to the mortality. So that's good. Anything else? Okay, so that's a good start. But here's what I put just as some ideas. So a little bit what we had, is it the drug treatment that's the problem? Either the drugs are incorrect or the dosage. A big consideration for us here again, is it that we're not detecting drug resistance? Okay, and actually many of my patients are dying because they have drug-resistant TB, but I'm not able to detect it. And so I'm treating them with drugs that are not going to be effective. Is it what we often just default to, blaming patients? Is it that the patients are coming too late to the hospital? So I can't help them because it's their fault. They came when they were too sick. They waited too long. Yeah. Or is it actually our fault that it's taken us ages to make the diagnosis? And so our diagnosis was delayed, either because we didn't bother to do the lumbar puncture for a few days, or we were waiting for a CT scan before we did a lumbar puncture, all the usual kind of things. Is it something to do with a complication of TB meningitis? So I think I'm treating the TB properly, but is it that there's problems with the host immune response? Is it that there's raised intracranial pressure that I'm not dealing with properly? Is it just a question of general quality of clinical care? So this is just to kind of illustrate how we go from identifying a problem and starting to think about what might be behind that problem. So how am I then going to find out more? So here I've identified something, I've observed something. I want to think about it a bit more. I've thought of some possible explanations, but I want to go and search the literature a bit. I want to understand a bit more what's known about this problem. So how do I go about searching the literature? how do we search for evidence on a clinical topic? And what are we looking for when we search? So let's stick with this example. How would you suggest I find out more about this problem of my patients dying with TB meningitis? Go to a database, okay. Go to Google Scholar, okay. What am I going to search for? What am I looking for? Similar experiences. Okay. So what studies am I looking for, or what research am I looking for? But look for case reports. Is that going to be the best way to start? Okay. Okay, that's quite specific. So I want to go and search for research around TB meningitis in central Durban. Etequini. Okay. Okay, so that's a good idea, yeah, but it's very focused to start with. What else might I do to start with? I mean, you've kind of said the right things, but I mean, what I want to know, first of all, is just, does my experience, half of my patients dying with TB, does that tally with our understanding of this health condition? Yeah. So, I mean, what's the best way that I'm going to get a general understanding of TB meningitis and mortality? Look at mortality data. Where would that come from? Published articles. Might come from specific studies. Stats essay. Yeah, they're not going to break it down to that level where you can really see mortality from TB meningitis. Hospital stats. Do the hospitals keep good stats? No. But here, let's just zone out. What we really want to just know is roughly what is our understanding of the mortality in TB meningitis, yeah? Okay, we're gonna later maybe dig down deeper, but first of all, we just want a rough sense. So what do you think the quickest, easiest way to find that is? What kind of paper might we want to look for? Okay. But again, here you're now getting more into how we're going to do our research. Whereas here I'm just saying, actually, I want to know, have I identified something that I need to think more about and maybe do research on? So I want to know, is my experience, my observation, is it consistent with what's known about this health condition? Good idea. So why is a review article going to help us? Okay, yeah, it doesn't necessarily have to be just clinical trials, but yeah, there's different types of review articles, and that's something we'll come to probably in later sessions. But what we want is something that just gives us a summary about TB meningitis and will give us some sense of what the mortality is thought to be. And it might tell us what it is in different settings, or in people with HIV versus HIV negative people, or something like that. So how would we find a good review article on a topic? Look at a database. Okay, okay. So which database are we going to use? PubMed, okay. So who's searched in PubMed before? You? It's not very nice. Okay. What else could we do simpler than that? We could Google. Why not? Google is our friend, no? Google is a great thing. You know? What would we type in Google? That sounds a good idea. Do we want a systematic review? Or okay. So let's just say review tuberculous meningitis. Okay. What comes up if I look here at the second one? I see here tuberculous meningitis, Nature Reviews Neurology. Now, I don't expect you guys to know journals and recognize them, but just to say Nature Reviews journals are going to be very strong papers that are generally going to be written by experts in the field. Okay. And here you can see, again, don't expect you to know, but Rob Wilkinson is a clinician scientist in Cape Town who's spent his life studying TB meningitis. So here we can just from a quick Google search, we can see, well, this is a review article written by an expert in the field. It's relatively recent. Okay, it's not current, but the sad reality is TB meningitis is not something where things are changing day by day and we're developing new treatments and things. So 2017 is okay for us to get a sense of the field. And the other thing that you can see is that this has been cited by about 500 other papers. So this is something that other people have found useful because they are citing it in their research. Okay. So just with a very quick Google search, I can find something that looks like it's going to be a helpful review article. Now, what is the next problem we face? Yeah, but I've identified this is what I want to read. So I want to print this out and spend tonight reading this article. What's the problem I've got here? Can't get the article. Oh. Okay. Access to this article via UKZN is not available. Okay. That's a bit frustrating, huh? Okay. Now, there are ways that you can get it, and I have this article from other places, but I'm just for the interests of just highlighting it to you that one of the problems with medical research is still that a lot of it is hidden from us. We can't access it because the university doesn't pay to access this journal, or we have, and it's not been made available open access. And so here I am, I've got this problem that my patients are dying of TB meningitis. I've found this really helpful article and I can't read it. That's frustrating, yeah? So thankfully, these things are changing a bit, and there will always be ways that you can get access to papers. So I'm just using it to highlight a problem. And even though I can't access the the paper, I can see the key points here. And here it's starting to give me some of the information that I think I want to know. So it's saying causes death, high rates of poor outcomes in children and people with HIV, important risk factors for poor outcome. So here you can see some of the things we were thinking about: delayed diagnosis, delayed treatment, advanced disease, TB drug resistance. Yeah. So I can see that this is going to be helpful to me. Okay. So that's one way that we can start off to get a quick update on a particular clinical topic, is just look for a good up-to-date review article, and that will give us our initial kind of grounding to then think more about a topic. Yeah. So let's just take another example. So have you guys been on the wards recently? Doing TATs and things? Okay, so what's the last case you did a TAT on? What was the health problem? Hepatitis? Hepatitis? Okay. Tell me one thing you wondered about on that TAT. And it can't be nothing. So something about the diagnosis, the treatment, the diagnosis, something about that patient that you saw. Okay. And her condition was hepatitis, specific hepatitis or unknown hepatitis B? Okay, let's say for argument's sake, it's chronic hepatitis B. Okay. So you heard that, and then what did you wonder then? What did you think? Okay. Okay. So let's just take the same. So how are we going to start off understanding that? Okay. Yeah. So that would be a good place to start. Yeah. Let's start just understanding hepatitis B, and then we can progress from there. Okay. So that's just just giving you that understanding of how we start that process. So often when you're going to be taught about literature searching and finding evidence, you're going to be taught about kind of formal ways of using the databases to find evidence on a particular topic. But what I'm trying to get across here is that life is much easier for us now with everything that we use, that when you're not doing things formally, you've not started yet a formal research process of doing, say, a systematic review on the topic. You just want to start to learn about something, then just use the things that are the easiest. Use Google just to kickstart things, to find out where things are. The other thing I wanted to introduce you to, because I just found it recently, and it looks to me really excellent. Has anyone heard of this website? openevidence.com. Okay, this is a clinical tool powered by AI, and I think it's largely built and designed for the US, but here I just tested it out to see whether this is something that might be useful. So just to give you the example, let's just ask it the question. Why is mortality high in TB meningitis? Okay, so that didn't take long. Does this look like it might be useful? This seems to look quite logical, yeah? It's saying it's due to several factors, so it doesn't come up with some answer saying it's because of X or Y, it's saying it's actually complicated, yeah? And it's starting to give us a sense of what those factors might be. And as you say, it's actually referenced. And if we go down, we can start to look at the references, and we can see, okay, these look like things that might be relevant. Yeah, here's a study of 608 people with TB meningitis and looking at what affected mortality. Here's a study looking at mortality among immunocompetent people with TB meningitis. Here's a systematic review of outcomes in TB meningitis. Yeah, so I don't want to give you the sense that this is where you do everything, but what I'm saying is this: there's obviously, with AI technologies and things, there's lots of things that are now designed to help us and to help us navigate things and to get information. And we should use these things when we find them helpful. Yeah. Let's take your example and let's see if it comes up with anything. So what was it? It was a abnormal taste in the mouth. Or sorry, it should be just does hepatitis B cause. Let's just try it. I have no idea whether it will come up with anything sensible for this, but yeah.
How see adverse effects that might be identified with the clinical.
Well, that's a really good question. The answer, of course, is no. The clinical trials were not rushed. The clinical trials happened quickly because they were done off the back of lots of other research up to that point on the platforms, on the vaccine platforms and things. The point here is that the vaccine trials, again, were not going to be enough to assure us that vaccines have no serious adverse effects. Yeah, because things that are extremely rare would not even show up in our phase 3 trial, which had how many participants again? Yeah, 20,000 or so. So if a adverse event, say, happens roughly 1 in every 100,000 people or 1 in every million people, then there's a good chance we're not going to see it in our trial with 20,000 participants. Yeah. And of course, that was 10,000 vaccine, 10,000 placebo. So what happens afterwards? What do we do to look at safety after products have been authorized? We can do phase 4 studies, or what else do we do? Yeah, so what we call kind of, or what's often termed post-marketing surveillance. So we do surveillance for safety events, for adverse events. So what do any of you know an example of something that kind of now we understand about the Janssen vaccine? Any adverse event that happened that we've learned about from surveillance? Guillain-Barré syndrome. You've heard of Guillain-Barré? Yeah. It's a very rare side effect of many vaccines. And so we were looking for it with the COVID vaccines. But we've only really picked up that it is a rare, very rare side effect through the surveillance that happened after we've rolled out the vaccines. Okay, so we know now that it is a side effect, but it's extremely rare. Okay, something like 1 in a million or so. Okay, so clinical trials are not the end of evaluating safety of a drug or of a vaccine. Yeah, you have to keep surveillance for safety events once you introduce a drug into routine practice, because something might come up that's very, very rare, but you'll only see it once you start giving it to hundreds of thousands, millions of people. Yeah. Can you think of any other examples that you've heard about of side effects that only became apparent once something was introduced into widespread practice? Thalidomide and babies. Yeah, yeah, possibly. Although I think there was also a problem there with how it had been developed and things. But yeah, that's probably a good example. Okay. So hopefully that's answered the question. So no, the research process was not too quick. It was quick because it had to be, because we were in a pandemic and because we weren't starting from scratch. We were starting from knowing about the platforms that were being used. And then some of these rare events like Guillain-Barré have now we've got a good understanding now from the surveillance. Okay. So coming back, what do we see? Yes, hepatitis B can cause abnormal taste sensation. Okay, so gives you a start. Yeah, I don't know whether that's enough to really be confident in the answer, but it starts to give you a sense. And here you can again see, okay, here I've got a couple of references that look like they might be relevant. So I could go to these and that would help me start off understanding what's going on here. Yeah. So again, just an idea to start using this tool, see how helpful it is, and just use it to try and follow through on curiosity. Yeah, because you're observing things all the time. Yeah, once you're on the wards, you're seeing all sorts of things that are new to you, that you won't fully understand, that there's no time to ask about, or you're too embarrassed to ask about, or the doctor's not going to give you the time to answer it. So jot down the things that you observe, jot down the things that you wonder about, and just start to, at the end of the day, at the weekend, whatever, just take 2 or 3 of those and just start going through a process of how would I find out more about that problem? Yeah. And so that will help you to just start to get a feel for that. I think we'll finish shortly, yeah, but let me just, if I can. So yeah, as I'm going to go into the literature, these are the kind of things that I'm asking, yeah? So is the mortality that I'm seeing here in my hospital in Durban, is this what other people see in other settings? Why are the treatment outcomes poor? Has anyone done anything about it? Has anyone tested any intervention to reduce mortality? Is there something I should be doing that I'm not doing that might help my patients? Yeah. And so I'm just going to follow through a little bit just to explain again the process of how clinical research evolves over quite a long period of time often. So coming back to your suggestion about TB drug doses, one of the things that people have always wondered about is whether we give the right doses of TB drugs for TB meningitis. And you would think that we would know what we're doing, yeah? Because TB meningitis is not a new health condition. It's been around forever. So you would hope that we would know what we're doing with drugs and drug dosages. But when you look at things and you dig deep, you find that actually we never tested out what's the right doses of drugs to treat TB meningitis. We just treated TB meningitis based on the principles that have been learned about treating pulmonary TB. Yeah. So if you go back to the early research on treating TB, it was all trials of pulmonary TB. Okay. And back in the 1960s and 70s and things. And there were never any specific trials of treating TB meningitis because it was a relatively rare condition. Yeah. And so when you then dig into this, you can see that particularly rifampicin, we know doesn't get into the CNS very well. The concentrations of the drug are very low compared to plasma. So is it possible that our dose of rifampicin is actually far too low to do what we wanted to do in the CNS? And so from starting to understand these things, you can develop a hypothesis that you can then test in your clinical research. So we can think, based on our understanding, can we think whether high dose rifampicin, so using a higher dose than standard, will that increase the concentrations of the drug, and will that change the outcomes? Yeah. And so you can answer this question, but it takes a long time. And here, what I'm highlighting to you is just the steps that it takes. So here is just a summary of the phase 2 trials for this problem. So thinking about using high dose rifampicin. So phase 2 trials were designed to tell us what, do you think? The safety of using that higher dose of rifampicin. So these trials, and you can see this is going back a few years now, they found that the higher dose of rifampicin, up to 30 milligrams per kilogram, was safe and well tolerated. Okay. And they got a sense that mortality was lower with the high dose rifampicin, but they were phase 2 trials. So they didn't have enough participants to show that clearly. Yeah. They could show from doing kind of pharmacokinetic sampling, they could show that it looks like there's a dose effect. That the higher the dose we give, so this is higher doses, the lower the mortality is. Yeah. This was not just done in Indonesia, but also in Uganda, and here specifically with HIV positive adults. And here they also found that that higher dose was safe even in the HIV positive group. But again, it was a small study. It wasn't able to look at the efficacy. So what do you think the next step is? Do a phase 3 trial. And that's what we've been doing over the past few years. We've been contributing to a phase 3 trial where we're testing this higher dose of rifampicin, 35 milligrams per kilogram for the intensive phase, against the control, where we just give the standard dose, standard Rifa-4, and that's 10 milligrams of rifampicin. And otherwise, everything is the same. So people are randomized to get either just the normal treatment or to get this top up with extra rifampicin. And then what do you think our primary outcome is going to be? Mortality. Yeah, we want to see, does this reduce mortality? So we've recruited now, we've just finished recruiting 500 participants. Not all here, so we've got about 120 participants in Durban, and then this trial's been happening in Indonesia and in Uganda, these countries that have been doing the previous research. And we're looking at whether it reduces mortality at 6 months. Okay? And so sometime next year, we're going to get an initial answer from the data to see whether it reduces mortality. Do you think it will? Do you? I don't. Why? Because there are so many other things that affect the mortality. If we go back to this, well, I've now got off again and I'm getting fed up turning it back on. But if we go back to thinking about why mortality might be high, we came up with quite a few ideas, didn't we? So even if it is partly because the doses are not correct and we should be giving higher doses, there might still be some of these other things also contributing. So if you again observe the patients dying of TB meningitis, you wouldn't just say, well, it clearly looks like this is just a problem of drug dosing. Okay, you'll see one patient where they had advanced HIV and they had also another opportunistic infection and they died. Or you might see someone who gets a line infection, gets nosocomial sepsis and dies. You'll see someone who's developed seizures that we don't manage well and they die from uncontrolled seizures. So just again, by your observations, you'll see this is not a simple thing. And if you remember when we put into the AI tool that said to us, well, it's a complex problem. It's multifactorial why mortality is high. Yeah. So the chance of one change just in the drug dosing actually improving mortality, the chance of us showing that is pretty small. I hope that we do, because we want to make things better and we want to improve survival. But it's quite a long shot. And that's partly just to show you that clinical research is difficult. It's not easy. Okay, you've got a clear problem. You've come up with very sensible hypotheses as to what could contribute. You've found a way to test it, to give a higher dose. You've shown that it's safe. You've got money. Someone's given you money to do a big phase 3 trial. And then we have to wait and see what the answer is. Okay. If we don't show that it improves mortality, again, maybe it's just because there's so many of these other factors. And so we can't just pinpoint this one factor and test it and show benefit. But let's see. So hopefully we're still meeting then when I will have some results of that trial and we can look at it together. So that was just one example to show you how clinical research for something like that is often a slow process. Okay, it's not that you identify a problem, come up with an idea that same evening, be able to do a clinical trial the next day and quickly find a result that says, okay, now we need to treat this condition with this drug. Yeah, clinical research is a slow process often and can be frustrating, but hopefully it gives you a sense of how we start to think about problems and start to address them with research. Yeah, good. So I think we'll finish there, and then we should start to think whether we want to talk more about finding evidence, how to find evidence, how to search the literature, or whether we want to start going beyond that to thinking, okay, how do we then appraise different bits of literature? How do we judge whether something's useful? How do we judge whether some piece of research is valid and whether I should trust it? So we can talk about next steps, but this was really just to give you a sense of and trying to get you to be more curious, observe things, question things, look up things yourself, start to get a sense of how do I find information on a topic? How do I start to come up with a hypothesis of my own? How do I then think about a research question and a research study design? Okay, so I think hopefully next time we'll move on with that. Okay. Oh, and sorry, just let me put this on again, because maybe before next time, I just wanted to highlight this site to you as well. Many of you seen this site, Students for Best Evidence? Okay. I'd really encourage you to have a look at this site because it looks really excellent. It basically looks like it's been developed by a group of medical students in Ireland, I think, but they're trying to build a network of medical students. And if I understand correctly, you could apply to join either as an individual or as a group. So you could take your group and say, we want to join this and be part of this community. But when I had a quick look, it just looks a really excellent resource for the kind of things that you're wanting to learn about. So, for example, if you go to topics, you can see searching for evidence. So how do I search for evidence? And it's got a number of blog posts about how to do literature searches, how to do a review, what is a guideline, conducting a systematic literature search. So there's lots of, and it looks like there's blogs, there's tutorials, there's links to other resources. Just looks a really excellent set of resources. So I'd encourage you to have a look, see if it's something you think might be useful for you, see if it might be a good idea to join it and to contribute to it. And then we can maybe go through it a bit more the next time. Okay. Great.